All right, good afternoon, colleagues. Those of you who are here and online, hopefully, maybe if you're online, you're going to listen today as you enjoy some of this beautiful weather in Indianapolis. For those of you unfamiliar with me, I'm Brian Dixon. I'm the interim director here for the Center for Biomedical Informatics, and I'm incredibly delighted to introduce our guest speaker today, who is one of our Sam Regenstrief distinguished lecturers. So here again, CME learner information. I don't think there's any disclosures today, so we're good to go there. All right, so I am thrilled to introduce Dr. Jessica Ancker from Vanderbilt University. Jessica is a professor in the Department of Biomedical Informatics, and she's also the vice chair for that department in educational affairs. So she directs their NLM T15 training program, much like myself and Titus direct ours here. So it's wonderful to have her here, and we talked about T15 things this morning. She's also a fellow in the American College of Medical Informatics. Her research focuses on optimal use of information and information technology, particularly in clinical decision making, and she's going to talk to us about that today. She also has a focus of her research around healthcare disparities and health equity, which really aligns well with our strategic initiative in that area. And her other sort of specific methods she uses in her research include looking at numeracy as well as user experience human factors, especially in clinical decision support. And the other nice thing about Jess is she's at this intersection of informatics and health services research, which many of us at the Institute are as well. So that's also helped really make the decision easy as to who we wanted to invite to be part of this lecture series. And finally, she does a lot of service to our profession in her role as the associate editor, or one of the associate editors, at the Journal for the American Medical Informatics Association, which is the premier journal for those of us in informatics. So thank you for your service there. We know it often goes unrecognized, but it's very important work to the field. So so at this point, I'll turn things over to Dr. Ancker, and thank you again for coming to speak with us today.
Got to get this microphone lower for me. Good. Thanks so much for coming, for having me here. I'm really excited to come here. And I'll just quickly say I'm a fellow Midwesterner, so you can call me Ancker. I do a lot of my work sort of at the consumer-facing side of things. I do some work in telehealth and health literacy. But really, what I wanted to talk about today is kind of a side hustle that I've been working on for a while, which is application of behavioral economics and behavioral science principles to informatics problems. And so I wanted to show how that's affected my work, and I hope, really, I think that my goal here is for you at the end of this talk to feel like, wow, that's so obvious. We didn't even really need her to talk about it. But I hope that then I would consider that to be a success if I led you to that point. So I'm going to start with a story of 3 staircases. You can see that these are all different. They give you options for getting upstairs. The one on the left was an office building that Josh Vest and I worked in at one point. And you can see that when you walk in the door, there's a very clear suggestion that you should take the elevators. It turns out that there is, in fact, a staircase. It's sort of tucked behind the elevators. It's very discreet, and there's a tiny little sign up there that says staircase. The middle one gives you these same 2 options. However, there's a clear suggestion that perhaps you should take these gracious, large, beautiful stairs, just like your stairs here. However, there is an elevator, and in this case, again, it's tucked behind the staircase. And then the final option photo there is my current office at Vanderbilt. In this one, there's no stair option. It's only an escalator. And again, there is an elevator sort of tucked around. So in each of these cases, The built environment is giving you a choice. You have certainly free will, you can choose whatever you want, but you can see that they're subtly suggesting that maybe one of these is the one that you should do, and they're trying to make one of these more attractive to you. So this is a case where in behavioral economics, this is called the architecture of choice. And it's easy to see it in the built environment that the architecture has given you a choice. It's chosen what choices you have available to you. In that third choice, you don't have a staircase available to you, but you still have options. And this architecture is also suggesting that maybe one of these is what you should be doing. So the first term I'm going to introduce is this idea of choice architecture. The choice architecture is the set of options that are presented to you and how those options are presented to you. And these options can be presented by the architecture, the built environment, public policy, or really what I'll be talking about is information technology, presents you with options as well. And then the second term that I'll be coming back to quite a lot is this idea of a nudge. And a nudge is some aspect of the choice architecture that encourages you, but does not force you to make one of those choices. So you still have the freedom to choose, but there's a little bit of a pointer that perhaps you should do one of these. It's important that it does not force you. So if I had actually roped off the elevator and said it was not in service, that would be a constraint. That would not be a nudge. That would be like, no, you can't do this. Okay, so choice architecture and nudges are a really useful way to think about any situation where we are interested in having people do something, but perhaps we do not want to take away their freedom of action. Here's an example in information technology. And whenever you buy something online, frequently it's sort of like the lower option here. There's, you automatically get enrolled in their mailing list and suddenly your inbox is deluged with emails that you don't remember signing up for. I used the screenshot from GitHub in the back there because it's one of the few times where I can see that you can get onto the mailing list if you want to, but it doesn't opt you in. You actually have to check that box to get in. So those are examples. Again, this is choice architecture. It's giving you the choice about whether you want to sign up or not, but there's a clear bias, I suppose, which depending on how they design that. And here's another one from sort of our office lives about whether your printer hooked up to your office. Remember when we used to come into the office and use the printers here? Whether it's defaulted to one-sided print or two-sided print. Again, you can always click through, figure out where that is and change it, but there's some setting in there, and that was set when the printer was installed, when the printer driver was installed, not even clear who set that. So those are examples, again, choice architecture and nudges. So today, in today's talk, I want to do three things. One is I want to talk a little bit more about nudges and decisions more broadly. I then am going to give you three case studies of informatics related and somewhat public health related nudges that with varying degrees of success. And then I will wrap up by talking about a new project that we haven't actually started yet. And so if people have ideas about that one, I actually really want to hear you. So to start talking more broadly about nudges, let me introduce another concept here, which is the concept of the default. And the default is defined as the thing that happens if you do nothing. So if you do nothing with the lower option there, you got onto their mailing list. If you do nothing with the GitHub one, you do not get onto the mailing list. So the default is an extremely efficient and powerful nudge. This has been demonstrated with a decision as important as organ donation. That in this country, we have an opt-in default. If you do nothing, your organs are not available for donation upon your death. But some countries have an opt-out policy, which is if you do nothing and you die unexpectedly, your organs are in fact going to be made available for donation. And you can see in different countries, this leads to different effective donation rates. The green bars are countries where you have where there's an opt-out, and you can see if a certain number of people opt out, they actually have to sign the little donor card and keep it in their wallet, just like we have to sign the little donor card and put it on the back of your driver's license or whatever. They have to do the same thing there. Whereas in the opt-in countries, these are the gold-colored countries here, you can see the opt-in rates are pretty low for organ donation. Even though if you survey people, they mostly say, yeah, I'd be happy, not mostly, but a lot of people say, yes, I'd be interested in being an organ donor. But the rate at which people actually do so is relatively low. So we can see that even when people say they'd like to do something, it's often easier to go with the default. Sometimes it's hard to figure out how to go past the default. Here's another example that I find a little shocking. I hope you find it shocking too. End-of-life decision-making. I can't quite understand how they got IRB approval to do this one, but they did. These were folks who were in hospice care, and they were making advance directives. They were signing advance directives. These are real patients making their own healthcare decisions, and they were given one of 3 advance directive forms. One of them, the one in the middle, was a standard. There were 2 check boxes, one for comfort care, even if your life is shortened, and the second one was life-extending care, even if your comfort is impaired. So the standard form, neither one of those is checked. They got permission to either pre-check the comfort care or pre-check the life-extending care. And these are the proportions of patients, real patients making their own decisions who chose comfort care. So with the comfort care default, you can see almost everybody did, very few people didn't. With the life extension default, only about 40% chose comfort care. And with the neither one, you can see it's right in the middle, which is very interesting, right? The next image, I think, shows probably how they got IRB approval, which was they revealed to the patients what they had done, and it didn't matter. So the left-hand bar is if they told you afterwards that they had pre-checked the box. The right-hand bar is if they told you beforehand they were going to pre-check one of the boxes. And you can see the bars are almost identical. It didn't, I know, isn't that amazing? So the deception, like sort of slipping it past people's awareness doesn't matter. Even telling them that you've done this doesn't really change their decisions. This was out of Chicago, and someday I'm going to go talk to the University of Chicago IRB and say, how did this get through? But anyway, this is how powerful that default option is. A question arises: how does it work? Why is it so effective? And I think the most persuasive discussion I've seen suggests that there are 3 mechanisms: effort, endowment, and endorsement. Conveniently all beginning with the letter E. Effort, obviously the default is less effort. If I do nothing, the default's going to happen. So that makes a lot of sense. Endorsement. It looks like the default has been endorsed, got the stamp of approval by somebody. Often that, in fact, is the case, that either the designer of the policy or the designer of the technology made, or perhaps maybe the majority of your peers have decided that that's the thing that they're doing. So we see decision makers often infer that there's endorsement, even if it isn't explicitly stated. And then endowment. Often the default is something that I gave to you. So for example, even the mailing list, I gave you an opportunity to be on my mailing list. Do you really want me to take it away again? That feels different from saying, here's a thing, do you want it? As opposed to saying, here's a thing, can I take it back again? It feels very different. So these 3 mechanisms are almost certainly all at play, and I think I'll give you some examples of how they differentially affect different sorts of situations. If you're interested in this topic, I've got a couple of reading recommendations. Nudge is by Richard Thaler, who won the Nobel Prize in Economics for this sorts of work, and Cass Sunstein, who's a relatively well-known thinker along these lines. And I'd also like to plug Eric Johnson's book. He was one of my mentors at Columbia, and his book does in fact mention my work in there, so I think it's a really great book. Okay, so that's the sort of nudges and choice architecture broadly. Let me bring it home to informatics, medical, and health decision-making with a couple of case examples. And the first case example I'll give you is about generic drugs. So I don't need to tell this audience that there's millions, billions of dollars in pharmaceutical advertising out there trying to get people to buy brand name drugs. I didn't have to declare this on my CME form, because this is like every possible brand. So big marketing push for brand name drugs. There's nobody who's really marketing generics. However, we know that for the vast majority of cases, the generic equivalent is in fact equivalent to the brand name. It is far cheaper, a fraction of the cost. And because of the lower cost, we actually see patients, particularly lower income patients, are more likely to take generics as prescribed because their copays are lower, and we don't see them, trying to eke out a same prescription over, to save money over time. So for these reasons, sort of general cost to the health system, but more specifically cost to patients, there's been a push, particularly in primary care, to prescribe generics when it's appropriate. When there's a generic equivalent, when we're all convinced that it's the same, go ahead and prescribe the generic. However, it's very hard to get doctors to change their prescribing practices. And so I'll show you sort of how successful Weill Cornell was in getting their outpatient doctors to start prescribing generics, which was not very. So this is the proportion of outpatient drugs that had generic equivalents that were generic. And you can see it was sort of hovered about 40%. And there was some academic detailing, there was some, grand rounds, CME sorts of stuff saying, hey, you should be prescribing generics. And there might be a little bit of an upward trend, but it's going to take a long time for that to make any difference. So about this time, the Cornell Health Information Technology folks, in collaboration with medical leadership, said, look, let's try to hurry this along. Let's really try to make this happen. And so they redesigned the order entry interface. So this is the electronic prescription that your doctor calls up every time they want to make a prescription. In the classic system, what you type is what you get. So in the old system, the doctor types or selects the brand name from the pick list. That's what shows in the electronic prescription, and that's what goes to the pharmacy, and that's the end of the story. In this redesign, they leveraged the power of the default here. Doctor types or selects the brand name, and then behind the scenes, the order auto-populates with the generic name. If that's okay, then that's what goes to the pharmacy and end of story. However, maybe you actually want the brand name, in which case, all you have to do is click one little box that says dispense as written, and you will revert back to the brand name, and then that's what goes out. So in essence, what we're saying is, if you want the generic, that's great. If you want the brand name, all I'm going to make you do is one additional click. Not heavy burden here. What happened? That's what happened. We got over 90% adoption of generics overnight, essentially, and it stayed stable. So the first question that most people ask me when they see this is, did the doctors notice? Like, were we pulling the wool over their eyes somehow? So first of all, we did announce this in an email, which probably no one read, but we did. we were transparent. We said we're going to do this, and that's what we did. Second, we did a little bit of a deeper dive. We did notice that some of the specific drugs where there had been some public debate about either bioequivalence or spectrum action, we actually saw higher override rates for those, so we know they were noticing. And the other thing that we noticed was that over time, there was a slow but steady increase in the proportion of doctors who were searching by the brand name. They were no longer searching by the generic name. They were less likely to search by the brand name. So it appears to us that people were actually perhaps learning the names of the generics, which often are a little harder to learn, and that's not what you learn from the drug reps, and often has more syllables and harder to spell, like all of that kind of thing. So we do think, as far as we can tell, that people were aware of this, they were okay with it. For folks who are sort of working in the pharmacy space, this was in New York State, before New York State had a pharmacy substitution law about generic substitution, which they do now. So I think that that's our first case example showing how powerful the default is and how it can change clinical behavior in a way that in this case, it was kind of a top-down directive, but it was a top-down directive that came primarily out of concern for patients. So we saw that it made a big difference here. So changing the default option can make a big difference, and yet it does not rob prescribers of the autonomy to make the decision that they think is clinically relevant and had minimal increase in burden. The second question I often get asked here is the ethics question. This is a very powerful tool. The default is a very powerful tool. Are we wielding this tool in an ethical way? And I do think that's something that we should always be asking with something that's this powerful. We clearly saw persuasion wasn't that powerful, so maybe we don't need to worry about that much. But something like this, we can really change behavior, so we should be thinking, is this an ethical thing to do? And these are some questions that various people have suggested that we think about whenever we're thinking about changing a choice architecture. One of the first questions is, who designed it the previous way? And did they have some sort of agenda? I mean, if the drug companies had designed the previous one and they were trying to get you to prescribe brand name drugs, I would think that's a situation where we should step in and redesign. Particularly in health and medicine, we need to be thinking about patient welfare, clinician welfare. Autonomy is extremely important in medical decision-making. And this idea of dignity, are we getting so manipulative that we're undermining human dignity? And I think that that's where the mandate for transparency comes from. If we're going to do something like this, say what we're doing and why. And then, point number 4 is something with any health and medical decision support we need to be thinking about. Do we have a plan to revisit this at some point if something changes, evidence changes? Are we going to stay up to date with the evidence? So I'm not going to say that we have answers for everything, but I am going to say I think these are really useful questions for us to ask before we do any sort of intervention like this. Okay, let me go on to our second case example. This one is about opioids. If you cast your mind back before our current pandemic to the last pandemic we were worried about, which we still are worried about, is opioid overuse and mortality. Mortality rates were rising very rapidly throughout the first part of the 20th century, particularly in the 2010s. And I think we're all aware that there have been many contributing factors for what's going on here. But one of the contributing factors did appear to be that prescribers were convinced through various marketing and other modes that it was safe to give patients a lot of opioid pain relievers. So 2016, CDC comes out and says, let's hold back here. In our new prescribing guidelines, we're saying for an opioid-naive patient, we would like to encourage much more cautious prescribing. We'd like to send them out with the minimum dose and the very shortest durations. We can see that the vertical line there is when the CDC guideline was published, and the dots here, the lines, are the proportion of Weill Cornell ambulatory prescriptions that followed this guideline, that would have been in compliance if the guideline had been in existence at that point. And this is a fairly strict interpretation of the guidelines. These are patients who walked out the door with new opioid prescriptions of 3 days or less. So that's a pretty strict interpretation. And we can see that that green bar is, yep, the proportion is increasing. We see some increase in adoption there. At this point, we got buy-in from the medical center, and we applied for a grant from the New York State Health Foundation to see if we could nudge this up a little bit further. So we did this again through defaults. This is an artist's depiction of the prescribing interface. This is not a screenshot from Epic. And typically, when a prescriber writes a prescription, we counted it out. It takes 23 keystrokes. And you would either type or select the drug, and then you have to fill out these other fields about how many pills and how many days and, you know, instructions for the pharmacist, stuff like that. So what we did, instead of adding keystrokes, which is what we did last time, this time we took away keystrokes. If the drug that they had selected was on our list of short-acting opioids eligible for this intervention, we auto-completed the form for them so that they only had to do 9 keystrokes. So if you wanted to send that patient home with 3 days supply, it was only 9 keystrokes. If you wanted to send them home with a month, that's fine. You didn't have to justify your action or get audited or explain what you're doing. All you had to do was type over these things. So again, a pretty gentle nudge here, but a lot of keystroke savings. And we saw the effect here. This is interrupted time series analysis. I also use this in my methods class when I'm teaching interrupted time series analysis. But you can see this was not nearly the kind of response that we got to the generics. So we see a jump, and it does look pretty stable over time, but it certainly was not the kind of enthusiastic endorsement that we saw for the generics one. And part of this was that we were, leadership decided that what they wanted to enforce or suggest was that 3-day minimum, which is a very short minimum. It would also be compliant with the CDC guidelines if we'd chosen a 5-day minimum. And then partly also that this was across all ambulatory prescribing, and there were, in fact, some departments that were likely to give a little bit more than 3 days post-surgery, things like that. So again, we have lots of room for the clinicians to disagree. One thing that was interesting about this one is that we did this at 2 sites. Our second site was the Federally Qualified Health Center, ambulatory primary care network in New York City. They had, at this time, about 18 different sites, very large primary care center. And you can see that they already were more conservative in their prescribing of opioids. They were much less likely to send people home with 30 days. So you can see that their proportion, what we would consider compliant or congruent, was about 50% before the intervention and remained about 50% after the intervention. So it really didn't change their prescribing decisions at all. However, if we look at the 6 months before and the 6 months after, and we count the number of keystrokes that were required to issue those, we got a 60% decrease in keystrokes for the same number of prescriptions. So, in fact, that FQHC was really happy with us. They're like, you just saved our doctors a lot of typing, a lot of work, a lot of cognitive work that they didn't have to think about. And they were already doing what we wanted them to do, and so we're kind of rewarding them for doing that. As you may know, clinician burnout is a big problem at the moment, and the EHR is not helping. And so reducing keystrokes could, in fact, be something that we should all be thinking about a lot. So even though we didn't get the change in their prescribing pattern, they considered this a big win, and they've been bragging about it ever since, which is great. So the takeaway from that case example is that another effective nudge is just to make the thing that you're sort of recommending easier to do. Rather than make the non-recommended thing harder, make the recommended thing easier. And I'm using the example of the curb cut for for wheelchair access in a sidewalk as an example here. Because even though these were initially implemented because of the Americans with Disabilities Act, it in fact turns out that they're easier for everyone to use. And so pedestrians and bicyclists and skateboarders will all end up using that ramp because it's easier to use than stepping over the edge. Great, so, we can, again, sort of think about these ethical issues in making this. This was another example of a top-down directive from not only the CDC, but our medical center in particular wanted to really encourage this. But they did, we announced it to everybody. We actually even attended a grand rounds and told the Department of Medicine. I still don't know that anyone really paid attention, but we told them. In the end, the fact that we did this through reducing keystrokes rather than adding keystrokes was generally perceived as a benefit, addition to clinical welfare. We do have, the opioid prescribing space is tricky because if you underprescribe for patients with chronic pain, you can get some very negative after effects, including people going onto the black market for stuff that they can't get through their prescription. So mandating that everybody go out the door a 3-day supply is clearly the wrong decision. Calibrating this so that the clinical judgment is still very involved and that patients have some recourse, I think is where this needs to be. Okay, so let me talk about my third case example. This was also in collaboration with the Federally Qualified Health Center in New York City. All of this, I forgot to mention, I've only been at Vanderbilt for 2 years, so these studies were all done when I was at Cornell. The Institute for Family Health is the safety net primary care clinic network across New York City. Primary care regardless of ability to pay. And they, even though they're a safety net clinic, perhaps similar to Eskenazi, they were very early adopters of information technology. They were early adopters of Epic in like 2003. And in 2008, they decided to roll out the electronic patient portal. And in the face of everybody telling them that this is never going to work, that they have a safety net population, a lot of impoverished patients, patients who may not have, particularly in 2008, may not have had internet access. They did not initially have a mobile app. So there's a lot of reasons why they were being told this is probably a waste of your money. And they very firmly came down on the side of it's our ethical responsibility to give patients access to their data. They may not all use it, but we have this responsibility. So very interesting organization. And so in 2008, they rolled out their electronic patient portal. And in 2011, I worked with them to do an analysis of their early adopters. And we found exactly what you can predict, which is there were clinical predictors of use, but there were also socio-demographic predictors of use that were concerning. We see Black patients much less likely than white patients. We see publicly insured people and uninsured people much less likely to use it than privately insured patients, and English preferred language over other languages. We were actually relatively early in publishing this sort of thing. I would say to all of you, if you're working in this space, don't try to publish this anymore because there's been like 15 years of people publishing the socio-demographic differences in adoption of information technology. What we really need is more publications on how to fix these. So, interestingly, when I did this analysis for Institute for Family Health, they said to me, we think this is not the whole story. Would you take a look at a second data set? And they gave me a second data set, which was what were the doctors doing? And it was really interesting. In those days, your doctor had to set up your portal account for you. In those early days. You couldn't just activate it on your own. So either the doctor offered it to you, or you'd see like a flyer in the waiting room and you'd ask for it. But in those days, nobody had ever heard of these things. For mostly, it was the doctors offering it. Then the doctor would set it up, give you your access code, and then you'd take it home and either you'd actually activate it or not, and then either you'd use it or not. So they said, would you take a look at what the doctors are doing? And when we ran the same analysis on the doctor behavior, it actually turned out that the doctors were preferentially offering it to the white patients and not the black patients. They were preferentially offering it to the privately insured patients, not the publicly insured patients. And they were preferentially offering it to the folks who were conducting their visits in English rather than in Spanish. We can speculate about what their reasons were. They may have been doing this out of the best intentions, thinking that these are the folks who have internet access, would be interested. However, unfortunately, the effect then rippled through, and we did see that the disparity actually started at the doctor end, not at the patient end. So, to their credit, Institute for Family Health said, we do not find this acceptable, and we're going to redesign our workflow, take the doctors out of it. And so they redesigned their workflow so that as soon as you walk in the door and register with the front desk sets you up with a patient portal, unless you've got one already, or unless you say, I don't want it. I think you can see how this endowment effect is now going to work, because I'm saying, here's your portal, but you can say no, I can take it back if you want. That's different from saying, do you want one, right? Okay, so doctor's out of the loop now. Now it's part of the front desk routine check-in. So I think you can see that in the old model, the default was no patient portal. If you did nothing, you got no portal. Now the default is portal. As soon as you walk in the door, you get one of these. So what happened, the first thing that happened was quite predictable and sort of not very interesting, which is more people started using the portal, which is great. The top line there that goes up to 96% is the number of people who had an offer that we touched and said, okay, you get one of these. So virtually 100% of patients now had been offered a portal. And then the next dotted line is the 32 is the proportion who actually activated it. So, but again, think this is 2011 in by now it's 2014 in a safety net population. They had 32% adoption of a patient portal. I mean, if you think about other people in 2014, they were not, with even much more affluent patient populations, they were not getting 32% adoption. So really not bad here. But what is way more exciting is the effect on disparities. And what we see is that some of those socio-demographic disparities went away entirely and other ones got narrower. So as comparison, I'll show you the female-male comparison. This one I would not consider a disparity. I think this is a situation where we know that women use more healthcare than men do, particularly primary care. So this is what we would expect, that in 2011, women were 29% more likely to use the portal than men were. And in 2014, it's pretty much the same, it's 32%. So there wasn't a lot of change there. But in 2011, white patients were 24% more likely than black patients to use the portal. But in 2014, that black-white difference disappeared. Now it's -7%, meaning black patients were slightly more likely, but it's not significant. So, so the racial disparity disappeared. We saw some decrease in the language-based disparity as well. And then I'm showing you here the insurance-based disparity. So private patients were 90% more likely to use it in 2011, and by 2014, they were only 46% more likely. This was this is not a causal study here. This was a quasi-experiment where they changed the policy, and then we looked at the effects over time. So, am I 100% convinced this is a causal relationship? I don't have that evidence. What I did do is we took a look at the statewide and the nationwide digital divide statistics from the same time period. And we do not see a narrowing of the racial divide nationally or in New York State during this time. And we don't see much of a we saw a narrowing of the more affluent, less affluent, but not to this extent. So we do think that this policy change was disproportionately effective with the most disadvantaged patients. And so we can now go back to these mechanisms and say, okay, well, why do we think it worked more effectively with certain patient populations? And I think, I mean, obviously now the effort was less for patients. They basically didn't have to do anything except walk in the door and they get one. Effort was much less for doctors. They didn't have to be involved at all, which is good. The endorsement, I think, obviously also works in our favor now. It's very clearly that your medical center wants you to have one of these. We're giving you one of these, so that's nice. The endowment effect definitely affects here. You know, this is your portal, or I can take it away. But I think what's interesting is we think about the effort. The effort is where I think we're seeing the disproportionate effect on different patient populations. If you have low literacy, the amount of effort that it takes you to decline the patient portal is higher, right? Because you have to understand what's going on or read the flyer about it and say, no, that's not what I want. So we probably have a situation where lower literacy patients are less likely to opt out, right? Because they are less likely to have that. Probably also people who perceive themselves as different socioeconomic class from their doctor. Are you likely to say no to your doctor? I mean, people who are, you know, sort of white collar, relatively affluent people treat their doctor as a peer. Well, yeah, you want me to do something? No, I don't want to do it. But in many situations, patients may perceive themselves, they may be treated by their doctors as, you know, less powerful, probably less likely to say no in this situation. So what we think is going on is that these patients who would be less likely to opt in now went home with that piece of paper saying, here's the URL, here's some instructions, and here's your password. And maybe some proportion of those were like, I'll give this a try. Also at this point, they did also at this point have a mobile app. So we have some folks who have mobile-only internet access, who are now able to use this. So it's interesting to see that the level of effort potentially differs by who the people are. It's probably not uniform across all different kinds of people. Okay, so takeaway from these three case examples. Changing the default is a very powerful nudge. Another really effective nudge is to make one thing easier than the other thing by taking away keystrokes. And I interpret the third case example is that we can actually leverage this thoughtfully to start to reduce some of the disparities that we see in particularly adoption of information technology, but probably in other areas of healthcare as well. I opened this talk with a question, which is, when is a nudge better than clinical decision support? Clinical decision support, I know we've got a variety of people in the room, but clinical decision support is often some sort of a overt reminder or pop-up, technology pop-up, something that says, there's a decision coming up, I want you to think about this and make a particular decision. So we can imagine if we used clinical decision support for every decision, then I walk in the office building and I get a sign in my face that says, hey, wouldn't you like to take the stairs today? Or I could just design a nice new building where the stairs are actually easy and pleasant to take. I mean, why do I have to make every single thing into a cognitive decision here? Why don't I just design things in a way that makes certain decisions easier to do? Probably is better for my cardiovascular health to take the stairs, so why don't I make the stairs a little bit easier? And yet, I should never take away the option of elevators, because there's plenty of people who cannot or do not choose to take the stairs, and so we need to have those options. So, you know, I would say in this situation that at the very least, these nudges are effective enough that if we have agreement that one of these is in fact the recommended thing to do, and yet we know that personal autonomy is important and people should be able to make a decision, this is a situation in which a nudge is probably appropriate. This agreement could be top down, like we need to cut the amount of opioids that are sitting around in people's medicine cabinets, putting people at risk, or it could be bottom up. You know, in my office, we decided we wanted two-sided printing, and so we went around and reset, you know, folks, you know, printer drivers so that they would do two-sided printing. But in any case, there's some sort of agreement here. Unnecessary work, if we want to reduce unnecessary work associated with one of those options, this is a great tool to think about, to put in our toolkit. When we want to preserve cognitive effort, why do I have to make everything a decision? Why don't I just allow people to reserve their cognitive effort for things where I really want them to think about it? Like, for example, what the right dosing is rather than how many days supply. And I'll just do a quick call out to my friend and colleague Sarah Rossetti at Columbia. The AMIA 25x5 initiative is an effort to reduce the documentation burden on doctors and nurses. So the amount of clicks, the amount of things you need to document, the amount of things that you need to write down is becoming a stressor. It's becoming one of the contributors to clinical burnout. So any of these sorts of efforts where we can reduce the amount of work, reduce the amount of clicks, reduce the amount of documentation is likely to bring benefits in the long term. I wonder if I do have this, I was going to wrap up with this idea of the new project, but I was wondering if I should just pause and ask if folks have questions or comments on any of the case studies or examples that I've provided to date. Well, okay, I've bludgeoned you all into submission. All right. Or the post-lunch torpor is kicking in. Okay, so let me wrap up with just a few minutes about this new project, which we haven't really started. Given that nudges are so powerful, and given that pragmatic clinical trials are really hard to do, so some way that we could marry these two things. This initial idea actually came from my colleague and collaborator on this, but I will, you know, happily sort of take credit for helping to elaborate it. Everything that I've showed you so far is a quasi-experiment, and it's studying the effect of the nudge. So, for example, we might have therapy A and therapy B, opioids at 3 days versus opioids at 30 days. I'm nudging you in one direction, and then I measure at the end how many people chose A versus B. And that's the analysis that I'm doing. To do this as a randomized trial of the effectiveness, comparative effectiveness trial of the therapies themselves, you have to redesign it a little bit. What we have to do, this was not my term, DART, the Decision Architecture Randomized Trial. First of all, we have to randomize. So certain clinicians would get randomized to the nudge toward A, and the other ones would get randomized to the nudge toward B. But then in the end, I'm not interested in who chose A versus B. I have to measure who chose A versus B. I would assume that more of the A folks would choose A, more of the B folks would choose B. But what I'm interested in then is downstream, what's the comparative effectiveness of A versus B for this disease or condition. So ultimately, the outcome that I'm measuring now is the patient-based outcome of glycemia control or whatever the outcome is. And the nudge has been the mechanism whereby I randomize. This has a couple of potential interesting applications. What we think the application would be, so far it's all hypothetical, is when you've got 2 or more therapies that are already FDA approved, widely accepted in practice, available, and they're kind of being chosen at haphazard anyway. And there's a lot of that. They've never been head-to-head tested in a randomized trial, and they probably never will be because, for example, if they're both generic, who's going to fund that one? Also, randomized trials are really hard to recruit for. A pretty considerable proportion of them fail just through recruitment failure. So there's a lot of reluctance to sort of invest in these low-risk trials of things that are already approved. They probably both work. But you know who's interested in that is Picori, really interested in comparative effectiveness of real-world therapies. So if we have a situation where there are multiple therapies that are currently available, currently being chosen at haphazard, and we could replace the haphazard with randomization, then perhaps what we could do is generate a lot of really high quality randomized evidence rather than be restricted to retrospective evidence. The idea here is that there are many situations, and I've given you a couple of examples here, where there are a lot of things out there that would qualify here. So there's several formulations of long-acting insulin that are currently used in hospitals. Are they equally effective, or does one of them actually work better? Well, maybe we could randomize and find this out. The threshold to start magnesium supplementation, it's widely accepted that low magnesium is a risk factor for bad outcomes in ICU patients, but what's the threshold there? Currently, it's kind of like people go with their gut. Maybe we could actually randomize and see if we could get some high quality evidence out of that. What would the sticking point here, the potential challenge and huge ethical challenge, is patient consent. What would make this, oops, out of order, okay. Given the amount of time, I'm going to go really quickly through this, but step number one is we need to demonstrate that these nudges do in fact meet the criteria for an instrumental variable. And I'm meeting with students afterwards, so if anyone wants to talk to me about instrumental variables, I'll talk to you then. But I'll just quickly say that in order for this randomization to actually work and have us be able to analyze this as a randomized trial, needs to meet 4 criteria. It needs to be associated with variation in the treatment variable. It needs to not be associated with confounders. And I've given you one example where it might actually be associated with confounders, so this is tricky. It needs to be not associated with the outcome except, needs to be conditionally independent. It's not associated with the outcome except via the treatment. And it has to go in the expected direction. It's called, it's like the no defiers rule. If I randomize you to something, it cannot make you more likely to do the opposite. So first part of this grant is we are doing a set of retrospective analyses from several existing nudges that were at Memorial Sloan Kettering to make sure they qualify. But the second part of the grant is the ethical part about consent. If these nudges are relatively unobtrusive, then the clinician is not going to necessarily stop and notice that they've been randomized. We have to inform them that they're about to be randomized, but these are designed to be, so for example, with the 2 insulin formulations, we might randomize some clinicians when they have that pick list that the one of them is first, and the other ones, it's randomized so that the second one is first. And it's a gentle nudge, but it's known to be effective. Do we want them to stop and notice that they've been randomized and then consent the patient? I think what would make this really scalable is if the IRB would say, given this particular situation, we actually think it's okay to waive consent. However, we don't 100% know if this is going to fly. So the first criteria, of course, is the federal regs on waiver of informed consent. And this is something where we need to demonstrate it's no more than minimal risk. These are therapies already in common use, that there's no adverse effect on the rights of probably either the patient or the doctor, if you think about it, that we will inform people either afterwards or beforehand, and that the practicability is that it would be not feasible to conduct this without the waiver. Just quickly, and say that for this project, we've built that into the grant. This is a methodology grant with PCORI. So aim 1 is we're actually going to sit down with groups of patients, groups of IRB members, and groups of clinicians, and do democratic deliberation sessions. These are not focus groups where I am asking you for your opinion on something. Instead, they are meant to be discussion sections where the group gets together and learns about a new topic that they're not familiar with, raises objections, tries to shoot it down, and comes up with recommended, in this case, it might be guardrails. This could be ethical under these circumstances, but not these circumstances. They might be able to come up with communication strategies. How do we explain this to people? Is there a way for people to opt out? Like all of these sorts of things. Some of the IRB considerations have to do with, risk and autonomy. So we are going to be using these discussions, these democratic deliberation sessions, to come up with potential rules and guidance, which we would then go back to the parent IRB and say, this is what we've come up with. Is it okay with you? Together with AIM 2, where we're doing the retrospective analyses of which types of nudges actually meet our criteria, then in AIM 3, we will be able to do one of these pilot trials. We probably are going to do it on the 2 formulations of insulin because we're pretty confident that that's a low risk decision. But other things might come up during the early phase of this. And I will say it's a little bit risky because it is possible that these democratic deliberation sessions might come up with a no way, no how, we don't think you should be doing it this way at all. In which case, I still think we'll be able to go back to PCORI and say, we have learned something useful. But it's also a little bit nerve-wracking because we might not actually be able to go all the way through. Okay, so with that, and the PI on this is James Flory, who was my colleague at Cornell and is now at Memorial Sloan Kettering in New York City, who is an endocrinologist, hence the whole. Okay, so this is what I wanted to talk about today, nudges and decision architecture broadly. I hope I've convinced you that we certainly have free will in the choices we're making, but those choices are in fact influenced by what our society, what our public policies, what our information technology, what our built environment is presenting to us and how it's presenting it to us. And that nudges are things that set people off in one of these directions, but don't force them to do that. The 3 case studies I gave were very successful in increasing adoption of generic drugs, moderately successful in increasing adoption of cautious opioid prescribing habits, and pretty effective at increasing adoption of a patient portal and specifically of reducing racial disparities in adoption. And then the new project, Nudges for RCTs, which I hope to be able to come back and tell you how that worked out. Have some citations for anybody who'd like a copy of the slides, and then I'm supposed to finish up with your CME survey. So with that, I've got just a couple more moments for questions, if anyone's got any thoughts or comments or questions for me. Yes, in the back.
I understand comparative effectiveness and why you would do a comparative effectiveness trial of 2 potentially equal treatments. But then, and I also understand why you might want to do a trial where you would test the effectiveness of different nudges. But I'm not sure I fully understand why you would want to do both a nudge and a therapy. Is it the same nudge?
Well, it would be randomized, first of all. The nudge would be randomized. Instead of me saying, I want you to do A, some doctors would get A, with the nudge A, and some of them would get the nudge for B. But I think the distinction here is that it's not like a true randomized trial where they're being assigned, where they're saying you have to choose A.
Okay.
And you have to choose B, which would be in a true RCT.
Right, I see.
It would be unobtrusively getting folks to choose A versus B.
So then in essence, then you're actually at the end testing 4 different things, because you're testing not just the effectiveness of A versus B for nudge A, it's A versus, it's both the therapy and the nudges you're testing, almost like a 4x4.
I think that's accurate, but the way we've been thinking about it is it's more like RCT with high dropout.
I see, okay.
So we're randomizing you, but you don't have to do the thing.
I see. So they'll be like intent to treat then. And
So yes, that's right.
I see. Got it.
Yes.
Okay. All right. Thanks.
And if it meets the criteria for instrumental variable, then we can do an intent to treat analysis. Good question, though. I didn't do a good job of that. Great. Well, I think I'm out of time, but I'm around, so I'd be happy to talk to people about any of these issues. So thank you so much for having me.